gives me great pleasure to welcome Professor Zanfina Ademi, who is leading the Health, Economics and Policy Evaluation Research Group at the Faculty of Pharmacy and Pharmaceutical Sciences at Monash University Australia. And you made a very, very long journey to be with us, so very many thanks for that. A warm welcome to you. We've been working together in the context of the International LP-A initiative, in which you've really championed the cost-effectiveness dimension to shift hearts and minds about testing. It would be fantastic if you could share some examples of your work where you've really been able to demonstrate a significant return on investment that has led to a real policy change. Please, the floor is yours.
Thanks, Nicola. Thanks, Magdalena, and thanks, FH Europe, for inviting me to come for a second time in Amsterdam within less than three months. So kudos to all of you for organizing my journey here. So today I'm not going to talk about how an impressive research I do. I would like to sort of take my research and tell you the story, how can you use some of those metrics and information for policy decision making. You heard from the European medicine, Maria, she spoke about what kind of information you need and how patients get engaged at the marketing authorization for new drugs. But now I'm taking you to the different point of the coin where what happens, how patients get engaged in a health technology assessment. So health technology assessment, it's more about when we talk about reimbursement. Yes, the new drugs are in the market, they are approved, they are safe and effective, but the government would like to know, are they effective in a real-world practice? Because we know a lot of those clinical trials engage specifically more healthy participants. They don't engage elderly, they don't engage pregnant women, they don't engage children. So when we go and look the health technology assessment, we not look only safety and efficacy, we look effectiveness, we look cost effectiveness, we look budget impact, we look affordability, and we look about opportunity costs. Bear in mind opportunity cost, because I'm going to be talking quite a lot about opportunity cost. You would think that government would care only about single disease. It's not like that. They always care about, okay, I'm spending this money today in FH. What can I buy with the exact same amount of money in a different disease? So they work in this way. So you have to understand this when it comes to the policy decision making. So I'm going to take you through the journey today. First of all, we have to define benefits and the importance of health economics and why familial hypercholesterolemia, why do I do a lot of research on FH? What is the current state of knowledge with regards to screening strategies and cost effectiveness? And I'm going to challenge some of the paradigm shifts that we are doing across the world, and specifically in Australia with regards to population genomic screening. And then what does the future hold? Can we pinch on different diseases to make a more useful of our healthcare resources? And at the end, I'm going to talking about future direction and implementation. So I thought to define the concepts before we move along. So first of all, as a lived experience, you don't buy the drill, but you buy a hole in the wall. So this is an important for you to understand. But also the payers don't buy a technology, they buy a benefit. So when you go and talk to policy decision makers, you have to talk to them about the benefits that technology is giving, rather than how great my technology is. And this is very important for a policy decision making. I've been to a lot of these patient organization meetings, but I thought to bring to light some of the issues, because the problem is bigger than just sort of talking about biobanks, talking about registries, talking about patient groups. We also have to think how we cut our pie, how we cut our cake when we finance the healthcare, how we pay our providers. How do we pay our providers today in the Netherlands? Is it fee for service, or is it capitation, or is it pay for performance? All of these methods, how we pay our providers, have a determined impact on patients' outcome. Because if in Netherlands would pay fee for service, it obviously would lessen the provider financial risk because they will be receiving the funding. But disadvantage of it is it's less effective on actually confirming to you that you will be achieving desired outcomes. So that's why a group, ICHOM, has moved toward more value-based healthcare. So what is value-based healthcare? So performance bonuses to reward the providers. There are a number of countries who have taken on board a value-based healthcare. In Australia, for example, we use value-based care and we incentivize the providers to deliver better diabetes quality improvement support. We can do similar thing for FH as well. So we will incentivize providers to deliver a better control of cholesterol levels. Similarly, in Switzerland, for example, bonus to networks of general practitioners to actually, if they achieve a better outcome on controlling patient, on blood pressure, on cholesterol levels, they will receive bonuses. Sweden has shown a great impact that bundled payment for hip and knee spine surgery has reduced tremendously their total health costs. And lastly, in Netherlands, diabetes bundled payments have shown a great prospect how you can actually improve the health outcomes of patients and quality of life, but at the same time reduce the costs. So now moving to why health economics. Why do we need health economics? We've spoke about effectiveness, we spoke about evidence-based. What is another term that we have to include in our general knowledge? But the reason why we use health economics is that not all prevention strategies that are in our current market are effective. So that's why we use health economics. And there is a growing gap what medicine can do and what is economically feasible to do. There are a lot of clinical trials who show benefits, but then when it comes to economic feasibility and opportunity cost, it's not feasible to reimburse in our current healthcare system. So that's why we have to make choices and priorities, and that's where the opportunity cost comes. So why and how and why the healthcare industry uses health economic evaluation? First of all, we use economic evaluation. The rationale for every economic evaluation is of research project, including drugs and screening. In this case, we want to determine if it's cost effective or not. Second, we use cost effectiveness for criteria for pricing. And obviously, this is to derive the optimum price to estimate early development of stages of healthcare technology, support for price negotiation across in Europe. Obviously, every European country has a different price negotiations, and every country learns from each other. There are countries who do reimbursement of new technologies earlier, and then, for example, other countries use a basket pricing to sort of determine what pricing they are going to negotiate for their own country. And also, we use health technology assessment or health economics for strategic marketing and instrument. So we want to differentiate our new product. It's better than the current market that the current product that is in the market. So now I want to take you through the health technology assessment and why is important for you health technology assessment as a patient. Maria spoke about how patients are engaged at EMA. So that is only for the marketing approval. But if we want our drug or technology to be part of our healthcare system or reimburse, there is a different process, which is the health technology assessment. And the health technology assessment, it's made up of different experts. So you have their clinicians, you have their health economist, statistician, but on those boards, patient sits as well. Even though it's not formally highlighted, but there are patients on those boards. So you have a scoping process where we develop and say, this is a new drug, these are the people who are going to sort of evaluate this technology, but the patient is also far front of it. And you as a FH community, you should strive in how to engage with the health technology assessment within European Union and in other countries. So in Australia, for example, we have Pharmaceutical Benefit Advisory Committee or Medicines Committee, which I'm part of. And obviously, we sit there and make decisions, but patient is included there as well for a decision making. So that's why it's important for you to understand that your voices should be heard at the health technology assessment process, because once the technology is reimbursed, then you are going to use in healthcare system. Otherwise, there is no worth having a drug in a market if it's not reimbursed for our healthcare system. So this process, it's quite important to bring our new technologies in our healthcare system. So health technology assessment, what kind of question does it ask? It asks, does new care model perform better than existing model paid currently under the public or private health insurance? So the question I would ask is, does the cholesterol screening without genetic screening, it's better than the new genetic screening that we will bring in a market? So these kind of the questions that health technology assessment asks. And obviously, you not only have to provide economic evaluation, whether it's cost effective, you have to provide information, what kind of return on investment to the healthcare it will bring if you would implement genomic screening. But also we consider the legal aspects of it, not to leave anyone behind in terms of equity, and also the ethical issues. And as you know that in a lot of clinical trials, we don't engage children, elderly, patients with dementia, so there are ethical issues that we have to address on those health technology assessment meetings as well. So any economic evaluation that you get exposed to, it's important when you talk to the government and think about reporting the results. The most important thing that you have to think is, and most of the economic evaluation, they have a common currency. It's called incremental cost effectiveness ratio. So the incremental cost effectiveness ratio is that cost required to achieve an extra unit of outcome. We always compare current practice with a new practice in terms of outcomes, but also in terms of costs. So is it going to cost extra money, or is it going to cost less money to implement this new technology? So in a vertical axis, you have costs. In a horizontal axis, you have benefits. So once you go toward there, you have a technology which is more beneficial. But if technology is less costly and more beneficial, that means that it's cost saving for our healthcare system. Majority of those technologies that are brought in market, they promise being cost saving, but majority of them fell into being more costly and more effective. So that's why we need to use the cost effectiveness threshold. And every country across the globe has a different cost effectiveness threshold. Netherlands, for example, has a threshold of 20,000 per quality adjusted life years. UK has around £30,000. In Australia, we don't denounce the ICER, but we usually use below 50,000. In US, they use an incremental cost effectiveness for every unit of outcome. It's around 100,000. So every country is different. In majority of low and middle income countries, they use the GDP per capita because it's less established as in other Western countries. So now going to familial hypercholesterolemia. So you've heard quite a lot today why we are studying FH. We've spoken about how prevalent FH, especially heterozygous FH, is in our community. And we've spoken about how FH causes premature death. And this increases either if you have homozygous FH, increases double more than you have heterozygous FH. With the current studies that we've shown so far, is that this is sort of, we've evaluated every possible cost-effectiveness study that is being published in Planet. So we've looked all potential strategies that have published in every country. And what we've shown is that if you would use cascade screening, as it's been done in Netherlands, for example, where you will test family members, in majority of those studies, it's been shown that it's cost-effective. So you can go back to your politicians and you can say, in every country, not only in Europe, cascade screening is cost-effective. But also opportunistic screening, when we use other ways of screening, has been shown to be cost-effective. Systematic screening as well, including population genomic screening. This is quite, for me, this is quite exciting, because this information actually you can take back and say, here you go, even if you compare with other diseases, this is more cost-effective. Professor Bird spoke about cholesterol years. This is quite important in FH. In 2017, we started a project where we said, we have to find a new way how we're going to inform the government about the screening for FH in children. We can't actually use the current risk tools to actually predict whether the patients with FH is going to have an outcome or not. What we've done, we've used data from Netherlands and Australia, and we found that if we include cholesterol years, we save around 10 years for every individual in the model. Meaning that those people are going to live 10 years longer if they treat it early, and if we include the impact of cholesterol years in the model. What does this mean? It means that for you, it's much more important to take your drug all the time, maybe 70 to 80%, rather than taking only for 1 year, 100%. This is the importance of taking your drugs every day, how important it is to control your cholesterol over the years. So in discussion, most of screening strategies show to be cost-effective. Cascade screening specifically showed to be cost-effective in most of the countries. And it is very exciting that we have technologies in place to screen, and we have treatment options. Other diseases, if they get screened, they don't have treatment options. FH does. So nowadays we can screen children, but also we can treat them early on so they can have a normal life like an individual person who lives in this planet. So why do we need a paradigm shift with regards to FH? First of all, I mentioned talking to a government in terms of cholesterol years, because this is a new concept. We have to think about not developing the disease. We have to think how we are going to extend lives of those people. So in Australia, we started the population DNA screening for FH people. And what we've shown is that, first of all, we conducted a cost effectiveness or economic evaluation of population genomic screening of adults aged 18 to 40. And we looked at what is the cost effectiveness if we would screen the whole population from 18 to 40. And we wanted to identify whether this is cost effective or not. I mean, some people might think, oh, it's easy, let's do back of the envelope cost effectiveness analysis. But usually when I do cost effectiveness analysis, it takes me years to bring all the clinicians together. And I always use a lived experience people in the table, because without them, I can't design the mathematical model. And usually it takes years to build the model. So first of all, you have to design how the model is going to look. What perspective do we have to take? Are we taking healthcare perspective? Are we taking patient's perspective? Are we taking societal perspective? We have to define very clearly the populations that we are studying. What is the intervention? Is it population genomic screening? Is the treatment available? Luckily with FH, we have treatments available. And what is the usual care? Professor Wigman mentioned that usual care currently for FH is that majority of people are picked up at age 45. And among those who are picked up at age 45, only 50% of them achieve targeted goal for cholesterol levels. So 50% of them are uncontrolled. So even though we are treating them, we are not achieving the desired outcome. So that's a waste of money. So we're using resources, but we are not achieving the targeted goals. And then we have to think about what outcomes? Outcomes that matter to patients. For me, we should think about outcomes that matter to patients. For government might matter quality of life, quality adjusted life years, years of life extended. But we have to ask patients what it matters to you. Does it matter to you to return back to work after you had that event? Or does it matter for you to work for most of your working life? So these are some of the questions that we have to ask in order to sort of produce a good evidence paper when we go to the decision makers. So usually these mathematical models are complex. We usually look to capture as many information as possible, and we usually look what is the current practice of care and what is the new way that we are going forward. And obviously we want to know what type of the screening we're putting in place, but also what kind of events that we have data to capture. With regards to FH, most of the information that we need comes obviously from Netherlands, having a rich data set, and from a number of registries across Europe, which have informed us about proportion of people who will die or who will have coronary heart disease events once they have the FH. So models are like Lego models. When I design them, I think of a Lego. So usually I tend to make sure that I include majority of the information that is needed for the decision makers. So what we found here is that when we did a population genomic screening, is that if a test is around 250, population genomic screening for FH is cost effective. When we look at it from a societal perspective, when we look whether you want to get back to work or not, it's cost saving. So we're saving money to our society. The most important part was that when we adopted these results to other high-income countries, so we did results for France, Germany, Italy, Spain, UK, US, and Netherlands. And what we've shown is that so population genomic screening from 18 to 40 was cost effective. When we looked at from societal perspective, was cost saving. One last thing I want to mention today is what does the future hold for population genomic screening? And this comes more to the opportunity cost. In Australia, we started a 10,000 pilot study where we have recruited patients with tier 1 diseases. What does that mean? Patients that have high cholesterol, such as FH, patients that have breast cancer, patients that have ovarian cancer, and Lynch syndrome. In this DNA screening program, we engage clinicians, but the far front of it was consumers as well, who have driven this part of the research. This week, this paper came out to show that early economic evaluation, I'm not going to be specifically on details because I'm running out of the time, is that the widespread preventive genomic screening for multiple diseases was cost effective. But the most important thing that you should get out of it, when we looked at the cancers individually, breast cancer, Lynch syndrome, and ovarian cancer was not cost effective. Once we added the FH in the equation, it became cost effective. Only when the FH was part of the large screening was cost effective. So, future direction and implementation. So to promote access and equity, we should think out of the box. We should think about population genomic screening, and we should think about newborn screening. Implementation, it's another hurdle, implementation science. Even though I might be providing the best available evidence in terms of costs, return on investments, implementation of results, it's never one-to-one. Policy making, it's usually all about the politics. What model of delivery population genomic screening should take place? To be honest, I myself don't know this question, so I thought to put this question out. Should we do it in primary care? Should the genetic counselors be involved in that, genetic nurses, or specialized tertiary care? So thank you very much for having me here and looking forward to joining the conversation.